Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your other host, George Margelis.
George, it's always lovely to be in the Pulse Pod studio with you, but I must admit that today I'm more excited than usual.
I have to agree with you there, Louise.
Yeah. And listeners, that's because George and I have decided to do something different this week and bring our listeners a special episode of Pulse. So we're not going to go into our usual breakdown of hot topics. George and I have a big long list, but we decided no, we're just going to forgo that this week because we want to dedicate the entire show to our guest.
Many of you know today's guest, Dr. Amandeep Hansra. As you're about to hear, Amandeep joins us today in the studio with a very personal story. Her journey as a patient during an acute medical episode she had a few months ago.
Yes. Now, for those of you who know Amandeep, and I know many of you do, we must stress to everyone that Amandeep is on the other side of that incident. She's healthy, back better than ever, so don't worry about her. But there is so much to learn from her story as a patient and her reflections on it. For those of you who know her, she is a deep thinker, very empathetic person. But as you'll hear in her telling of her story, despite her empathy and her huge depth of understanding about how the healthcare system works and what it might be like to be a patient, her reflections on her journey have taught her a lot. And I think those reflections are a story that deserves retelling in its entirety, uninterrupted.
It was a fascinating session, and really we could have gone on for another half an hour, if not longer, with her. And the reality is, I've discussed in the past some of my own family's interactions with the healthcare system, but Amandeep has gone above and beyond, boots and all, experiencing the healthcare system in its full reality. So without further ado, you will gain a lot from listening to our chat with Dr. Amandeep Hansra.
Today on Pulse, we're doing something a little different. We're joined by one of Australia's most respected voices in digital health, Dr. Amandeep Hansra. Amandeep is a GP, a health tech leader, an investor, and a long-time advocate for innovation in healthcare. She's the founder of Australian Medical Angels Investment Syndicate and Creative Careers in Medicine, a community for clinicians who support each other as they explore creative ways to practice medicine differently. But earlier this year, the tables turned. And in a sudden and deeply personal twist, Amandeep found herself not behind the stethoscope, but on the other side, as a patient facing a series of debilitating symptoms that landed her in hospital. Within mere weeks, she was back to living her best life, but answers are still elusive. Today, Amandeep is generously joining us to share her journey, not just as a doctor, but as someone navigating the complexities, gaps, and opportunities in our health system firsthand. This is a story about communication, access, digital innovation, and what happens when the doctor becomes the patient. Amandeep, it's so great to have you on the show. Welcome to Pulse Pod Studio.
Thanks so much for having me, Louise and George. I'm super excited to be here and looking forward to our conversations today.
We are looking forward to this chat very much.
All right, so let's start at the beginning. Act 1. Can you take us back to the day it all started? What happened and what made you realise that something was seriously wrong?
Thanks, Louise. And I am here today completely and utterly representing myself as a GP who turned into a patient, not representing any of the organisations that I work for. But yeah, look, I've had a really interesting experience being on the other side. And, normally I'm very fit and healthy, and lots of people know, pack lots in and usually very active and get myself to lots of different places and I have a very full life, and I think sometimes you can take for granted that your body kind of gets dragged along as you're navigating all of your exciting pursuits, whether it's career or personal. But earlier this year, I started to become unwell and ended up with some neurological symptoms that were quite worrying and problems with sort of pins and needles, numbness, weakness in part of my body. And it was something that I did initially ignore, as most healthcare professionals do, is ignore symptoms that you would tell a patient to go straight to hospital with. But after a bit of ignoring and the symptoms becoming more severe, I realised that I did need to seek medical attention. And that was beyond my own self-diagnosis, Googling, treating that I was trying to do in the first instance. I couldn't even bring myself to call an ambulance, but knew I couldn't drive and ended up taking an Uber to a local emergency department. And that was the beginning of my journey in the health system as a patient with way too much knowledge, having the medical background of all the things and machinations that were going on in the background.
It's interesting because as a doctor, you often have a bit of a bipolar response to symptoms. You either overreact, and we probably all remember times in med school where we thought we had every possible infectious disease out there at the same time. And then as you have more experience, like you said, tend to ignore symptoms thinking that they're temporary or I can't have this. What made you make that decision that, okay, these symptoms are really serious enough for me to jump in an Uber, as you said, and go to hospital? And how did you go about describing those on the other side? Did you use medical terminology or did you prescribe them as a normal patient would?
Great question, George. And you're right. Like, I did initially start off with, I have to be dying before I would go to a hospital, because I think many of us understand the pressures on the system and don't want to be another person in ED that sits there for 8 hours, taking up time, which could be spent with people who have got really legitimate, serious concerns. And you never think you're that person. So I did kind of ignore the symptoms for longer than I should. And I think it was literally when I couldn't walk that I realized that this is not normal and I probably do need to be seen somewhere. But even then, couldn't walk, definitely couldn't drive, but thought, I don't want to take up precious resources, so I'll call myself an Uber. And it was quite funny on the drive because Uber was trying to have a friendly conversation and was like, what are your plans for today? And I'm like, I think I put in the Uber that I was going to the emergency department, but it was quite a weird moment for me. And then I think once I hit hospital, then sitting in the waiting room, you have 1,000 things going through your head, George, as you said, because suddenly you're starting to do the doctor's job and putting yourself on the other side and saying, well, what would I think this would be? And you kind of think of all the red flags, scariest things possible. And when I first approached the desk in the emergency department, they said to me, it's a really long wait. It's a Saturday. There's lots of people in this room. Could you potentially go to an urgent care centre and see a GP? And I was trying to explain to her that I was worried that I might be having a stroke and I wasn't sure if urgent care centre would be able to do much with that. And she's like, no, it's a very good urgent care centre. We've got it down the road. And she explained to me where it was. And I eventually had to tell her that I was a GP because I was like, I'm a GP and I wouldn't be here unless I really thought that I needed to be here. And I said, if you would just let me see the triage nurse, and I promise if it's not anything urgent, I will leave and go to the urgent care centre. And so they did let me see the triage nurse, but I did worry a bit because if I'd listened to that advice and gone straight to the urgent care centre, I probably wouldn't have been in the right place for the care that I needed. And then when I saw the triage nurse kind of did her assessment, and then she was like, oh my God, you definitely need to be here, and started the whole process of trying to rule out that I wasn't having a stroke. So that certainly was an interesting experience, and just understanding what it's like for a patient coming in and sometimes potentially being talked out of how serious your condition might be. And you're already umming and ahhing whether you should be there. And I know we have people the other way around who don't have serious conditions and probably shouldn't be sitting in our emergency departments, but it just goes to show how much pressure the system can be under, that they have to kind of make those calls without having all necessary information.
That's a really interesting point because I've had an experience recently with one of my kids. The urgent care clinic did a great job for what he had, which was a fracture. But yeah, you would think a front desk, someone saying, I think I'm having a stroke, would be enough of a trigger to sort of say, this is a category, at least 2, if not a 1, to push you through.
Yes. And to be fair, not everyone has medical training that's on the front desk. And I got to see the right person eventually, but that was the entry into the system.
Anything else from that time in the ED waiting room? Were you there for long?
Yeah. Look, I mean, you do look around and you think this is a place. We talk about Australia having a sick care system, and you see the sick care system really in action when you're in a waiting room in an emergency department. And if you weren't sick before, you probably feel a bit sick afterwards. But it was very busy. It was your typical pictures where you've got people standing up out the door, and you do really sort of acutely feel the pressure on the system when you walk into those sorts of situations. And I think I recently saw a picture, must have been somebody's LinkedIn post. I think it might have been from the Netherlands, where they had these empty emergency department waiting rooms because they have such a great primary care system. That means that a lot of people don't end up escalating to an emergency department. I'm not saying that we necessarily can get there, but I could certainly feel the pressure, and it does make you question whether you should stick around and stay. And I also realised we didn't have a lot of options for private EDs in New South Wales where I am. I know a lot of other states have them. I was a person who probably could afford to pay, and I was like, I would love to take some pressure off the public health system and whatever I need to pay to make sure that I was giving care to the people that really needed it. So there is something to be said for looking at the models that we have for emergency care across Australia. But yeah, it was quite confronting to see so many sick people. And luckily I wasn't there for long, because I think when they actually thought I was having a stroke, they were like, we need to get you in straight away. And then everything kind of just happened really quickly.
Saturdays are pretty famous for metropolitan emergency clinics being pretty busy. I mean, I remember 30 years ago when I was an ED, Saturdays were the busiest day. But as you point out, what are the other options you have? And the reality is that other options may not have been suitable. In your case, I'm assuming, scans and whatever were involved. So there's a whole bunch of other things that needed to be looked at.
Yeah, absolutely.
You described, obviously, you had the front desk experience, the discussion around urgent care. Once you got past the triage nurse, did anyone sort of be an impediment or block other than those discussions, or did you feel like you're being welcomed into the department?
When you have something that's an emergent condition and it is category 1 or 2, I think pretty much life becomes a bit of a blur at that point. And so I do remember having scans, people coming in and talking to me, and all I could think of was, contacting my family, because I thought this is more serious than I originally, anticipated. But in that moment, I think that's when the vulnerability really hits you, and you feel like you have to hand over all of your control to somebody else, and you can't really think rationally for yourself anymore in that moment. And it's quite a scary feeling when you're used to being in control. Like for all of us as professionals, it's very rare that we are in situations where we are just, having to be participants in a process, which is what I sort of felt at that time. There was a lot going on. I didn't feel like I understood what people were saying at that point. I knew I was being wheeled into things and having scans and things. I didn't really actually understand what I'd had done or what the results were. And that's not to say that people weren't necessarily communicating that to me, but I feel like when you're in that vulnerable position and your headspace is not in a information processing or accepting state, I really felt even more confused and lost and didn't know what was going on. And I thought, wow, if I'm a medical professional and I feel like this, how does every other patient in this emergency department feel right now? And how scary it is when you just have no idea what's going to happen next.
Have you had any reflections since then on what could be done to change that process? Because, like you said, you're in a very vulnerable state and you've lost control, and this applies to everybody. In an environment that wasn't as rushed, the consultations can be recorded and you have information you can reflect on. But when it's happening so quickly, but your body and your mind is going into shock, so yes, you lose some of those higher level cognitive functions. Is there any reflections that you have on how that could be done better?
Yeah, what I realised was I was there alone. And, I think when you're alone, and obviously it took some time for my family to get there, there's nobody really advocating for you, nobody who's putting all the pieces together. So one minute someone's in there saying, here, sign this piece of paper because we want you to be admitted as a private patient. And you're not in a state to be signing a piece of paper. I remember just not even understanding what she was saying at that point, and I probably signed it and then, I don't know, signed my life away. I had people coming in and out asking me various bits, but there was nobody who was connecting it all and being kind of the link between everything that was happening. It felt every little piece of the process was very transactional, of everyone has their role, they'll come in and do their role and leave. And then we talk about continuity of care in the primary care sector, out in the broader world. This was like continuity of my experience as a patient, of just someone knowing everything that was happening to me and saying, okay, they've been and told you that you're going to go for an echo at this time, and this person's said they're going to organise this test, and then someone's coming in to do some bloods. And rather than having that sort of overarching person or process or something that was like taking it all in for you, you were just seeing the little bits of things coming and going, and you just didn't know really what was happening next. So I almost felt like it would have been nice to have had an advocate. And if it was a family member, great. But if you don't have family with you or anyone with you, who is that person who is there by your side kind of going, did you understand that? Did you know what just happened? Do you know what's going to happen next? Yeah, and I don't know how we do that in a resource-constrained environment. I don't have the solutions to that, but it did feel like the experience could have been more friendly. We talk about patient-centered care. This is exactly what patient or person-centered care would be, is that you would actually have somebody supporting the person at the centre of it.
Interesting you make that comment. I've had quite a bit of experience with family members being their advocate when they end up in emergency departments, having a big, large ethnic family with lots of older people in it. And it's interesting having that advocate, and someone like myself, and I never go in saying I'm a doctor. I just sort of start having discussions with them when we're there. And usually within 2 or 3 questions, they sort of ask, are you medical? Because they pick up from the scope of the questions. But the expectations of someone who's in pain or confused or whatever, making those decisions is important. I guess there's potentially a role there. This is where maybe medical students would play a good role. It'd be a good opportunity to follow that journey and follow a patient, because understanding what a patient's journey is, it doesn't work out really well on a whiteboard or on a PowerPoint slide. It's watching it in reality.
100%. Yeah, you've nailed it, George. I think that's it, is that how do we use what we've got available in the system to fill that gap of really supporting the patient? Because so much of your recovery and your health is your mental state as well. And I do think that the intense anxiety that I had of, I think a lot of healthcare professionals suffer a bit of health anxiety because we know how bad things can be when they go wrong. Just having that be addressed and alleviated would have helped the physical recovery. I think, we're all one integrated being. And I think we forget about the mental health side of it when somebody is in that confronting situation. But I think, I'm very open to thinking about solutions to that, because I think we underestimate how much patients go through during that process.
Do you think being a doctor helped or hindered you in receiving care during those initial assessments? Was it a pro or con?
Hindered, definitely. I didn't want to know. And also, this is absolutely no disrespect to my poor intern colleagues who had just started week 1. And this is the worst time to go to hospital, is week 1 of internship. And I could tell some of them who were doing the neurological exam, I felt like coaching them. I was like, oh, no, you didn't actually test for this. And I was like, stop. And you also know what they're missing, because you're like, you haven't done this or you haven't done that. And so I kind of wished I could switch off that part of my brain and just be a lay person who didn't understand really, everything behind it, because then you just see all the things that aren't being done right or the things that could be done better. And as I said, no criticism, but it was a timing thing that these people are very junior and they've just started, and, this is their job, is to come and do examinations on new patients that come in. But yeah, definitely didn't help. I wish I wasn't a doctor at that time.
And you probably thought back to your first week as an intern, what it was like based on intern.
For the PTSD from that week.
Yes. And when they walk in and say, I'm going to put a cannula in you, and George, you would remember this, you'd just be like, oh no, please, can you call someone else? I know you need to practice, but not on me.
Oh, how true.
Yeah.
Oh no. And timing-wise, how long do you think you were in ED before you were admitted onto the ward?
Oh, look, I think, again, I was probably a bit unclear of times at that point, but I do remember being moved to sort of like a short stay unit type part of the hospital. And the other thing is they're very noisy places. It's loud. There's lots of stuff going on, bright lights, people coming, going, like you can't rest. And I was there quite late, I think, until I managed to get a ward bed. And again, I understand, bed block, and they're waiting for patients to discharge, and I could hear all the conversations, and I kind of knew all of the issues around logistics in a hospital. So I could sort of understand why it was a delay to get me up onto the ward, but I was just desperate to get some sleep at that point, and obviously try and get away from all of the bright lights and noise, and really still had no idea what was going on because we hadn't made a decision about a diagnosis. But once I got up onto the ward, it was a little bit calmer, I have to say, briefly, until the chaos of the ward kind of takes over. But it was a while, but I can understand why.
And then you're in hospital for a while, I understand. And in that time, were you able to access as a patient your own test results and clinical notes? Like, what access did you as the patient have to this information that was being gathered about you?
Louise, I had nothing. And again, the disempowerment that you feel where you don't know what's going on about you. And the interesting thing was when I came into ED, before I went into ED, I'd had a couple of tests that I'd organised as an outpatient because I was trying to investigate what was going on myself. And I went in and I said, I've had this scan and I've had these bloods. The bloods, they were like, it's going to take us forever to find those bloods. Let's just do them again. So immediately my brain went to, my role at the digital health agency where we talk about duplication of tests, and if we could just have access to them on the My Health record, we wouldn't need to repeat tests, because they were like, it's a weekend, it's a private pathology provider, it's going to be a nightmare to try and get those results, let's just repeat them all. And immediately I felt this gut reaction of, this is all the stuff I work for, don't do this. And then the scans, they were like, oh, this was done by an external radiology provider. We don't know when we're going to get the results. It's not going to be easy. So they didn't say we'll repeat the scan, but they said we'll wait till weekdays and then see if we can get hold of it. So again, not having it directly up there on the My Health record ready to view, I think that would have made a difference. And then I would have also had it, but I didn't have any. And, I saw moments where, people were typing notes and I was trying to understand what they were typing anyway. But you do really feel like it's being done to you. You're not part of it. So again, you don't have the visibility. But I think the worst part was just not knowing what was happening next. So I think I might have spoken to you about this, Louise. I was staring at this TV screen where you're watching awful daytime TV, and I was like, it'd be great if you use that screen for a better purpose, and actually educated me on, where am I up to in my journey of all these tests that you want me to have? What's going to happen next? Rather than just having wardsman walk into your room and say, hop into the bed, we're taking you for this test, and you had no idea it was coming up. And so using that to communicate to the patient of, this is where we're up to, this is what, is happening to you, this is what's going to happen next. A bit like the flight path that you have when you're on a plane. And you can see where you are, how many hours to go, what's the temperature outside. If I had something like that to at least tell me where I was in this journey of investigation and treatment, I think I would have felt more empowered as a patient. But that was missing. I had nothing on the My Health record. So I didn't feel like I had any information about what was going on.
And you have all this time in your hands. I mean, unless you're that sick that you're asleep or, I'm in a coma, you have all this time on your hands in between the assessments where you could be making good use of it. And I guess because you didn't have this access to this information, that must have taken a big psychological toll, an emotional toll as well, to be able to be in your own head thinking of what's happening next? What are all the things that could be wrong?
Yeah, I wish someone had taken my phone away from me, to be honest. I think, I've never been on Reddit before, but I joined Reddit because I was like, there's other people out there who've had these weird symptoms and what's going on. And the worst part was, as much as I love all my friends and colleagues, they were all medical. So the first thing they wanted to do was figure out what was going on with me. So I'd kind of want to call them for support, and they'd be like, okay, so just remind me, so which area did it start? Because I've got to try and map out the anatomy of which region of your brain could it be affected? And I was like, oh God, I just want you to ask me, what was the food like? Can I bring you something to eat? And I love them. But I think when you're very medical, you're in that world, the anxiety just, takes over, and then feeling unable to access results and be able to actually understand what was going on was very difficult and challenging. And also just waiting for investigations. And I think I've told you about this too, Louise, is that I was, really waiting for this MRI to rule out one of the things they thought it could be. And I'd sort of gotten promised having it the next day. And then it was like 4 days later where I finally got it. And those 4 days were excruciating of thinking what could be on it. And I remember when I went down to the MRI unit and I said to them, I'm so sorry that you've been really busy for the last 4 days, because I assumed they'd been under the pump. And they were like, we haven't been that busy. But they said, we just received your request form this morning. And they picked up a piece of paper and they said, someone must have lost the original one. Don't know what happened. 4 days. I don't know. How much does it cost for a bed, stay every night? $2,000 or something. And, you think about the money that could have been saved. I probably could have gone home. I was definitely improving from a motor function. I could walk. So I was like, well, I could have just gone home and sat at home. The other thing was I went online, and it's just, again, someone should take my computer away from me. And I could see that I could book a private brain MRI, that afternoon on the first day where I was waiting. I was like, so I actually asked them, I said, could I leave as an outpatient, go get this MRI, I'll pay for it privately and come back in? And they're like, no, you have to stay here, you can't go anywhere. And again, I was thinking about the system and the utilization of our resources of if we've got an empty scanner sitting somewhere and they've got another one that's, well, at that time I thought was really busy, how do we better utilize the resources that we have so that we're actually making the best of the limited resources that we have and make sure patients get a timely outcome. If you think about not just the cost to the system, but the cost to the patient experience of having to wait for investigations and things like that, it really adds up.
Absolutely. And you said that when you finally went down to the MRI, it was a paper. Just curious, does this hospital have an EMR of some description? Like, do they have digital records?
They do have an EMR, but I saw a lot of handwriting going on. I mean, back when I was in the hospital years ago working, you'd see the nurses writing down obs onto their hand, or a bit of paper, and then go back and you write it into the notes. But here I thought, you would have at least had connected vitals machines that would automatically upload into EMR. But I saw the nurses again writing on their hands and then going over and entering things. And I asked them a couple of times, I'm like, it's just kind of annoying that you have to do this twice. And they said, we do have something that connects, but it doesn't really always work. And so no one uses it. And I was like, no. I was like, this is all the stuff we work on. And then it gets to this pointy end and then they don't end up using it anyway. And I watched how much pressure the nursing staff were under. And I have a whole newfound respect for nurses that work in hospitals, but also saw we have a huge problem if the workforce continues that way, because it is not going to be an attractive place to work with the number of pressures that they're under. And they were short-staffed every day that I was there. I kind of got an announcement that there weren't enough nurses on that shift. And I watched how much stuff they did, and a lot of it was duplication of entering things. And so I think we have these systems that are hybrid, which actually kind of make things worse, where you're sort of partly digitized and partly not. So I don't know deeply about that hospital's kind of digital roadmap and strategy, but it was clear that they didn't have everything in place that they needed, like e-referrals. It was clear that they didn't have the ability for nurses to just upload, or they did have it, but it wasn't working well enough, upload observations. And as I learned on my discharge, they didn't have e-scripts. So there were a few things that I thought, we've got this. No. So this was interesting because when I was fine, and this is actually my second admission when I went back in and I got discharged, and they said, we just have to wait for the intern to come up and write you a script. And I said, the intern was busy at a code and was probably going to be gone for a few hours. And I said, look, just let me go because it's getting late. And they said, if it's too late, you'll just stay another night. And I said, no, there's no need for me to stay another night. I can go. And I was thinking about writing the script myself, and I thought, no, don't do that. But I said, I can go and find someone else to write the script. And I said, do you mind if I contact the specialist directly who had admitted me? So I contacted her, and she wasn't at the hospital, but she said, you know what, I can write you an e-script and send it to your phone, and you don't have to wait for the intern. So when I went and told the nursing staff this, they were quite confused. They were like, but we don't normally do that. Then, we need the paper script, like the intern will come and write that. I was like, no. And I was like, I have an e-script. I can go. I can leave. And they're like, we haven't finished the discharge from me. I was like, okay, it's fine. You can send that. Upload it to my health record. I can get it later. And they were just not at all familiar with that process or comfortable with it. And I just realized how much time it saved because I got this e-script and was able to walk out of there and potentially save an extra night in hospital.
So it's interesting because, like I said, one of my kids was in hospital recently. We had a very similar thing. We had to wait for the specialist. He actually ended up going private. And there's a long story about how challenges of the public health system made us go private halfway through a procedure. But it was literally one of their old prescription pads.
Yes. So much, sort of legacy systems that we're still using. We've still got a long way to go. And I think I forget sometimes when I live in the primary health sector because I feel like we have made lots of leaps and bounds. And you go back to different parts of your health system and you see that there's still a lot of manila folders, writing notes, paper scripts, even just stuff that we think doesn't happen anymore. But we've got such a heterogeneous sort of system, really, from a digital health literacy and capability perspective.
Years ago, we used to have those observation charts at the end of the bed, so at least you could pick one of those up and see what was happening.
Yes, I know. I did miss those. I was like, I want to see what's happening to my blood pressure. Yes.
So now someone on their computers on wheel is doing all the work and you have no idea what's happening behind the screen. And you always look at that worried look on their face as they're typing. Is that because they can't see the screen or because something's wrong with what they're typing? It's a challenge.
100%. I actually did have a friend of mine who contacted me and said, I've got access. I wouldn't recommend anyone doing this. But he said, if you want to know what's going on and what they think is your diagnosis, do you want me to go and check your electronic record? And I was like, no, that's fine. You don't need to. But I think everyone was recognizing that I felt so like this information asymmetry of just having zero understanding of what was going on and the medical team having the knowledge, but feeling in the dark.
Do you feel if you'd been more of a squeaky wheel, you may have gotten more attention, or is it because you tend to be a fairly nice person, Amandeep? You don't push yourself or push you around, but give me my numbers there, that would have helped or hurt.
Well, do you know what? I think that I was waiting because I ended up having a lumbar puncture and got a complication and had a CSF leak from it. And I was awaiting a blood patch to patch up the CSF leak. And again, I was waiting quite a few days to get that. And I just was like, wanted to get it done so I could get home. And I remember asking every day and they're like, yeah, you'll be on the list today. You'll be on the list today. And every day I was not. And if anyone's had a CSF leak, it's excruciating. You've got a severe headache. You can't stand up. And eventually, I think on the last day where I just had kind of like lost it a bit, I started to cry, I think. And then I think the team got really scared and they were like, oh my God, she's bawling. I think we need to get this done. So I didn't complain, George. I just cried. I think people get quite scared of like people crying. So I think then they realize, okay, if she's like, not in a good state, we should just really get this. And then I think they advocated to get me done. But you're right. It's terrible that in this system, you actually have to be the one that complains or be the squeaky wheel, be loud or have the mental breakdown before somebody will say, okay, we'll prioritize you. And it's no one's specific fault. Like it's just the nature of the system that we've built. And it has become very impersonal and it has become under so much pressure that I think patients are the ones that are paying the price because of the experience that they have.
So it's interesting because, obviously your situation, because it was a bit of a diagnostic dilemma, the public hospital system with all its resources are ideal. Like, so when my son broke his ankle, we spent half a day in the public system. They were quite honest, sort of saying, look, it's going to be quite a bit of a wait here, but hey, if you go next door to the private, we can get it done this afternoon. And literally, that's what we did. We sort of packed our bags, walked across the road and got it done that day. But again, it depends on the situation. He had an x-ray showing a broken ankle. We knew what the treatment modality was just there's going to be maybe a week wait for that treatment. In your case, that doesn't work that way because you still had lots of questions to be answered.
I did, but I also felt like a lot of those tests were available in the private system. I probably could have navigated it, again, if I'd had an advocate or somebody helping, navigated getting a lot of those investigations done privately. And I did feel a bit guilty because I can afford, to pay for this. I don't want to take up public resources.
Although technically you were. You did sign off as a private patient, so...
I did, you're right.
So you were paying for it in the end.
That's right. That's what that form was that I was signing. I knew there was something good that was going to come off it, alleviate my guilt. So I think you're right. I think it's about we have lots of resources in our health system. It's just making sure that we're using the right resources for the right people at the right time. And I know this is a bit of a cliched thing, but in that situation, there may have been ways, if I could go back and design my experience, I would have designed it differently, I think. It just got rid of a lot of the anxiety that I ended up with.
And your case was really complicated. Did you ever get an answer on what happened? Not that you need to tell us what it was, but, do you got a resolution?
No, but not 100%. I think it came back to medicine is not an exact science. And what we do is we rule out the nasties. Treatment is time and you see what happens to your symptoms over time. I'm still figuring some stuff out. There's still further investigations going on. But I think at the end of the day, it made me realize that we still have so much about the human body that we don't know, we don't understand. And despite all the tests and technology that we have, sometimes we still have to kind of make an educated guess about what happened or what's happening. And so there are limitations, but I have to say that I did use my own personal experience to test the quality of AI in this diagnostic challenge, because I think that's where one of the interesting parts of AI application in healthcare could be, is that when we face with these diagnostic dilemmas, what can AI pick up that the human brain can't? Because if I sometimes think about it, often I can only put two sort of pieces of information together and see there's a relationship. But, when you've got AI able to put together multiple pieces of information and see really nuanced trends in something that we don't see, what could it come back with? And I absolutely love all the clinicians that were involved in my care, and they were all beautiful, wonderful, competent people. But some of the most interesting perspectives on what could be going on actually came from using AI. And I'm not saying that people should do it. Obviously, I'm medical, so I can kind of assess whether this is taking me down a really dangerous path.
So hashtag patients use AI. We're advocates for that.
Yeah, but it also shows me that this is what our patients are doing when they don't feel like they have an answer. Like, I'm not unique. Everyone else is out there is going to say, if I don't have an answer, I'm going to check whether AI can help me. But it also gave me that experience of what is it like in this era where we have these tools available on our phones and our laptops at home, where we can get answers that if we don't have faith or trust in the system or in our healthcare professionals, that we've got these other alternatives that we will sometimes use. And if we don't involve healthcare professionals in understanding how to support patients doing that, we're going to be at risk that they're going to just follow that advice. And, that's why that quote's so overstated, but the whole idea of practitioners that don't use AI are going to be taken over by those who do, because we do need to know what our patients are doing with AI.
We did on a previous episode discuss the new Chinese AI first hospital, and sort of, again, integrating those sort of services into it is important. And had you been able to, at triage, use a touch screen to enter symptoms, and that would have triaged you into automatically, they may have saved a bit of time as well. The hospital experience being what it is, when you came out of the hospital, how well did you find that sharing of information about what happened in the hospital, outside the hospital?
I assume you actually do have a GP.
Yes, I have. I actually saw, I've never seen the value of having a GP as much as I did when I came out of hospital. And she was just very caring and very kind. But again, I watched as I had my appointments with her, how under pressure she was. But I have to say that the post-hospital experience wasn't great either, in terms of you have to be your own advocate. You have to navigate the system yourself. You're a bit confused, dazed, you're still recovering, and you don't remember everything that you were told. And you were like, was I supposed to see this specialist? And I got booked into clinics I wasn't supposed to go to. And then I didn't get booked into clinics I was supposed to go to. And I was on the phone to the public system just going, why don't you just take me out of that and I'll go and sort this all out privately, which obviously then requires you to go to your GP. And the GP didn't have access to the discharge summary. And again, I was like, why is it not on my health record? And I did have the piece of paper. And so I was able to take pictures of that and share it with people. But again, just didn't feel as seamless as it should be. I would have expected, okay, the discharge summary gets done, it goes up to the My Health Record for the patient to see, it goes to the GP for them to see, and they can see it on the My Health Record too. It goes to all the other clinics that need to see it, and everybody has the information that they need. It wasn't quite like that. It was me, again, being a bit of a courier, taking the bits of paper to various places and making sure that everyone could have the information they needed to do the follow-up that was required. And particularly if you're moving between the public and private system, that's another whole kind of barrier to have to go over, because then sometimes they don't have access to what's in the public hospital system. And to this day, I still do not have all of the blood test results from my hospital stay. So they exist somewhere in the ether, but my GP's been unable to get them. My specialists haven't had access to them because they were private, and I don't have access to them. And I think I need to probably carve out a day of my life to sit there on the phone or walk down to medical records and actually ask for a copy of those. But it's crazy to think there's information about you sitting out there that you've never received the results of.
That's crazy. And didn't one of the tests had to be sent off to America?
Yes.
Do you have a copy of that?
I don't. Oh, actually, you know what? My wonderful specialist did actually email me a copy of it. So I did get a copy from her. But again, when I think about where is all my information, some of it's in my inbox, it's been emailed to me by various people. Some of it is pictures that I took of paper that was given to me. Some of it is on the My Health Record. Some of it is on your iMed app or your app from your pathology or your radiology provider. Some of it's sitting with the GP. My information is just scattered across the system.
And this is from effectively one encounter.
One encounter. And I just think about all those people that have multiple chronic conditions. And, what I went through, I'm very blessed. I'm here and I'm back working and feeling a lot better. But there are people who have multiple chronic conditions, who have cancer, who have terminal illnesses. And if I was this kind of stuck with the whole system, I I feel for them in terms of how they navigate it. But it was a bit of a wake-up call for me to say, well, you actually didn't understand the patient experience as well as you thought you did until you were completely put into that position and disempowered in many ways, the way that a patient is. They would have it even worse than me because at least I had a little bit of, agency.
We keep on arguing, if we improve health literacy and we improve digital literacy, then a lot of these problems will disappear. But you hear someone with high digital literacy and high health literacy and still struggling to do that.
100%, George. So imagine our most vulnerable patients. You add in a language barrier, you add in some cultural aspects. I was in a shared room with 3 other men who'd all had cardiothoracic surgery, and I was the only woman in there. And I was just thinking, for some cultures, that would have just been unacceptable to have had a curtain between you and 3 men. But I was thinking about all that stuff while lying in bed, just thinking, how can we do this better? Like, it needs to be done better.
Well, having been advocate for a number of older patients in similar boats with many from a cold community, you just see so many things that rank you the wrong way. And then you sort of think, well, how do we solve this problem? But at the end of the day, it comes down to resources. You saw the hospitals understaffed, the nurses are being run ragged, the junior doctors in February still don't know how to request something. So it's challenging.
But the thing is, George, there's also so much wastage as well. And I was just wondering, if we could sort of zoom out and say, well, where is the stuff that's happening that shouldn't be happening, that we can save money on or save people's time? And then how do we take that and then repurpose it? If a nurse doesn't have to re-enter OBS every time from a hand to a computer, could she spend a bit more time advocating, caring for the patient, explaining what's going on? There's she or he, sorry. And I think there's a lot of things that happen that are actually unnecessary or more complex than they need to be. And if we take some of that away and put the resources in the other places, which goes back to kind of the human aspect of healthcare delivery and having someone that just you want to feel cared for, which is hard in that system.
Yeah, absolutely. Well, we're so glad that you are back at full strength, full capacity. You're 150 for everyone else's 100. But now you've had time to reflect as well. So, when the doctor becomes the patient, that role reversal. So how has your experience as a patient changed the way you practice your craft and the way that you think about it, particularly with people with, complex or unexplained symptoms?
I think I have a lot more empathy, Louise.
Sorry to interrupt, but you must be one of the most empathetic people I know, and I'm sure I've never seen you as a patient because that would be weird because we're friends. But, I imagine your level of empathy is already so high, and yet you're saying you think it's higher now.
I think it is higher in particularly sort of more of my sicker, complex patients and understanding how it can become a full-time job just trying to keep yourself alive and well. And also leaning in more to help them navigate the system, because I now realize I had a lot of assumed knowledge. I assume patients have that knowledge and they don't. And it's very hard when you're in a vulnerable position to even bring what knowledge you have to the front and use it to advocate for yourself. So I definitely think I have become even more empathic for my patients who are trying to navigate difficult situations. I think what also it struck me is that there are some very simple, basic things we need to get right. I mean, it's all great, well and good to talk about AI and genomics and all of these great technologies, but just good communication, sharing information, making sure that people understand what's happening to them, making them feel cared for. There's so many relatively small things in healthcare that will make big differences in patients' lives if we did it. I had one nurse when I was particularly anxious who just took 5 minutes out and sat down with me and said, I'm going to put this meditation app on just for you to calm down a bit and try and help you feel a bit better about what's going on. And it was the nicest 5 minutes of my whole admission that somebody had taken. He probably had 1,000 other things to do that moment, but took the 5 minutes out to sit down and, help me calm down. And my blood pressure came down. I felt so much better. And I just hope we don't lose that humanity part of healthcare, which is so desperately still needed, and particularly in a system that is under strain. And technology can't do all of that. It needs to be driven by the humans.
Learnings from other sectors, because I remember having this discussion when I was working in the hospital sector years ago about how a project planner would have had a Gantt chart for your journey, and everything would have been in stages, and you would have been informed along the stages. But we're never taught to do that in healthcare. We're taught to respond to what's happening at that moment, not think about it as a process. And whilst we've seen some of the work from Macquarie University showing that when you don't use guidelines, you get worse outcomes, we have those guidelines. A, we don't use them. B, the patients don't even know about them. So, it's some sort of way of structuring those sort of things. Years ago, I saw a movie called The Doctor with William Hurt. I don't know if you've ever seen it.
No.
It's probably before you guys were born. So it was back in the last century.
All right, homework for us. I like it when you give us homework, George.
Thanks, George.
Yeah. It's a story of a epidemic of non-empathetic doctors. It's a surgeon who finds himself with throat cancer, therefore being in hospital, unable to speak, and the challenges he finds as a patient going through the system. So it's really a good movie, you get to see it. But again, that idea of how empathy plays such a key role in what we do. And sometimes if we overemphasize the empathy, we can sort of get over some of those other issues. But if we don't have empathy and we have those other issues, it really becomes a painful journey for the patient and for everyone involved, because, doctors don't like having unhappy patients bawling in the bed. That's always a challenge.
Absolutely. And, you get better outcomes if you just improve that patient experience. It's not just about the pathology. We're not treating the disease, we're treating the person. And we forget that the person has a mind and brain and emotions, and that's such a critical part of healing.
Obviously, you've seen the roles of the clinicians in the hospitals. I know you're very active with the creative careers in medicine. Other roles in medicine which would have made your journey more efficient or effective, not necessarily clinical roles, but people with clinical skills using other skills to make the experience better?
Yeah, it's a great question, George. And I think that we've talked a lot about team-based care, multidisciplinary care. We talk about all of that stuff when we're talking about healthcare reform. I think that we haven't really sat down and worked out what are the important team-based roles that we're going to need for a healthcare of the future, where we have technology that plays a certain role, where we have people working more to the top of their scope, where we do have some workforce shortages in some areas. How do we support and augment our existing healthcare professionals with other skills that are needed? I agree. I think that nobody has the time these days to provide that kind of support, concierge, advocacy sort of role. And I'm seeing this in some of the primary healthcare models that we're looking at redesigning. And some of it is around having that coordinator role of somebody who kind of can oversee everything and say, I deeply know your case and your health status and what you need to get done, and I can be the advocate for you. I can help you navigate the system. I can help be that source of support for you, and actually help then liaise with all the other parts of the care team. And if you translate that into an acute setting, having that person by your bedside as you move from ED to the short stay unit to the neurology ward to the cardiothoracic ward, wherever you're going, that there's somebody with you along the way. How amazing would it be to have that role and create that role, and then allow the nurses to do what they need to do, allow the doctors to do what they need to do, and really optimize our healthcare workforce? Because I think it's hard for me to say, hey, doctor and nurse and whoever else saw me, physio, like, you should have tried harder to be more empathetic and spent more time communicating, when they've got to do that for lots and lots of patients. So I do feel like there is an opportunity for us to look at the roles in healthcare that we're going to need in the future and start working towards and training people in that.
That may be a great topic for discussion at the annual conference. You tell us a little bit about your annual conference for CCIM coming up.
Oh, yes. I'm so excited. And one of the things lying in bed, I kept thinking, the one thing I will be disappointed about is if I don't get myself better enough to go and run the CCIM conference, because that's something that I think, is kind of purely mine, in a sense that, I'm the driving force behind it. I mean, I've got a great team. They would have done it without me anyway, but it's a passion of mine, and I've been doing it for 5 years now. And so we're bringing together hundreds of clinicians from across the country to come and talk about the future of healthcare. The theme this year is Let's Create. So it's really about creating what's the future like, all the different roles that we would play as clinicians in the healthcare system, whether it's as advocates, as leaders, as innovators, problem solvers, and really getting us to explore those different options. I mean, the fact that we're all sitting here on this podcast, not something that we ever thought we would be doing when we were training as healthcare professionals. So that's our conference in August, 23rd, 24th of August in Melbourne, and got tickets that have gone on sale. So if anyone's interested, definitely buy a ticket. And any healthcare background, I think will find it of great value. And Louise is delivering a great keynote for us. So looking forward to that. And hopefully, George, you'll be there too. But yeah, it's definitely an event not to miss.
I attended your very first one in Sydney many years ago. And I remember at the time you had your two beautiful kids behind the desk handing out the badges.
No.
They're a lot bigger now.
They are.
Well, we confused them because I turned up with my son. So there were two Dr. Margellises and they had to work out which was who. But it was a great event. So yeah, I'm looking forward to the next event.
Yeah, and CCIM for our international listeners, because we have people from over 50 countries who tune into the show, Creative Careers in Medicine. And Amandeep, didn't that start with a Facebook post? Like you had no intention of building this global community at first, did you?
No, I mean, it was actually the event that I wanted to run, and we did put a post out and say, does anyone want to come to this event that we've got this idea about? Yeah, and then we ended up with 400 people that wanted to turn up, and we thought we'd get like 40. So it grew and grew, and now there's 25,000 members in our online group, and we run various things, and we have jobs that we advertise and, courses that we promote. And so it's really become this kind of force of its own of really getting people to expand their thinking about what a career looks like in the medical space.
Amandeep, you are an absolute legend, and everyone knows you in digital health in Australia. And if they haven't globally, or they find out about you now. Thank you. It's been incredibly generous and very kind. And I get that it's a very vulnerable thing to tell your patient journey story to anybody, let alone to a big audience. Hopefully you've just felt like you're just having a chat with George and I, but it's been great. And I think your story has so much value for all of us, whether we're wearing our patient hats, our clinician hats, our healthcare executive hats, our researchers hat, our technologist hat. There's so many learnings that can come out of your journey. And thank you so much for coming on the pod and sharing your story with us.
Oh, thanks, Louise and George, for your hospitality, having me here and asking me some really thoughtful questions. And I do want to say a huge thank you to everybody that did step up and help look after me when I needed help. Every individual clinician, healthcare worker, everyone that supported them were fantastic. I think what I'm trying to highlight here is it's not an individual person's, failings. This is really a system that we need to look at and get right because we owe it to our patients.
It's been a real pleasure talking to you, Amandeep.
Thanks.
Thanks, guys.
George, I'm a little bit speechless after what Amandeep had to say. I feel so grateful that she wanted to tell the story and was able to come to the Pulse Pod studio and do it with us.
Look, it was a fascinating story of someone who's obviously deeply ingrained in the healthcare system, knows all the technical solutions that are out there, and yet in reality, the system itself struggles to provide the sort of customer experience or the client experience that we talk about in so many other sectors into healthcare. Amandeep really demonstrates that despite having health literacy, despite having digital literacy, despite having private insurance and having all those other benefits, the healthcare system still has a number of challenges from a consumer perspective, and we really need to think about the patient's journey more fully. And I think she really highlighted that it's a journey ahead for all of us.
Yeah. And George, I really loved your suggestion as well about maybe there's a role for medical students to play in that advocacy type role that Amandeep clearly said was needed.
Absolutely. Look, I think medical students, but again, this is where we need to start rethinking the roles involved in healthcare. I mean, we tend to think about the doctors, the nurses, the allied health, but even Amandeep's Creative Careers in Medicine provides opportunities for people to play different roles. We even touched on the roles AI could even play in this journey. And so there's lots of thinking to be done here, but I think if we can get that patient journey, and we've spoken to people like our good friend e-patient Dave and others around, now this is a global problem. This is not just a local problem here in Australia.
Yeah, yeah. And I think it goes to show as well, George, we deal with a lot of younger clinicians who are like, hang on, this wasn't what medicine, I didn't think it was going to be like this. And, oh, I want to do a startup instead. Like they quite quickly want to change the system. And we always advocate, unless you really hate people, can't stand the sight of blood or something, like please stay a clinician, even part-time, because I think as Amandeep's story shows, just the depth of experience and understanding that being in the system gives you to be able to understand the depths of the challenges that are there to help you work out what solutions could be.
Absolutely. And as I said, there are opportunities here for startups to help improve that journey. So tying the clinicians to non-clinical people, to AI tools, we talked about simple project planning tools so that the process of being managed in an acute care service, yet alone, imagine how much more complicated this would be if this is a 30-year chronic disease journey as well. So there's so many opportunities here.
Oh, absolutely. And if we look at things like the learning health system, I'm seeing some papers these days about lean types of methodologies being applied to healthcare, which of course came out of manufacturing with Toyota. But I was thinking when Amandeep said, I had this TV watching, crappy daytime TV, I was actually thinking the poor girl, they could have given her Netflix or something. But anyway, so she's watching crappy afternoon TV and thinking, well, this screen could be used for other purposes, and being able to chart her journey. I was like, oh, that is a brilliant idea. It shouldn't be game changer. I mean, that should just be standard. But how that would have alleviated everyone's anxiety, even if you went, oh, sorry, I know we were going to do that test this afternoon, but now we've had to reschedule it to tomorrow morning. But at least then you know that it's coming. And I thought that was really ingenious as well.
It's interesting. I mean, this is one of the few areas where aged care probably is doing better than healthcare, in that many aged care facilities do provide that screen as a tool for informing people about what to expect next, what's coming up on the menu, what activities are available, who your next carer is coming in. So we need to really integrate those sort of ideas into our models of care.
Yeah, yeah. And I was thinking about the last episode as well. We talked about OpenAI and their new device and how something like that, which is of course pure conjecture at the moment, but how that could be used in healthcare. There's lots of challenges, but that idea of, if you didn't have that advocate person with you, whether there's a role for AI at some level, which obviously would need to be done in a very empathetic way rather than just, here's your Gantt chart, but it's possibility there.
Look, it comes back down to innovation. In an ideal world, we'd have a well-trained, well-informed advocate by our side, but we know that's not physically possible in the current environment. AI and tools associated with AI, with a bit of empathy and with access to human resources to fill in the gaps, I think we have an opportunity to do this.
Yeah, yeah. Well, anyway, thank you again, Amandeep. I hope all of you Pulse Poddies really enjoyed the chat with Amandeep. And let us know if you really liked it as well. George and I can consider bringing you other special episodes in amongst our normal takedown of the fortnight's hot topics in digital health.
Yep. Amandeep, she always has been a powerful advocate for digital health in Australia.
Oh, absolutely. Yes, we need her. And of course, everyone has to get to CCIM in Melbourne.
Absolutely. Looking forward to that event.
Yeah. And it's at the Pullman, which is right across the road from Albert Park. So if you've always wanted to visit Albert Park and see where they do the Grand Prix, you can duck out over lunchtime or bring a partner and say, well, you can go to Albert Park and have a look around there, go for a walk while I'm at the conference. CCIM is a great event. She just curates such an interesting program. It's not unlike any other health/medical event I've ever been to. Really looking forward to that this year.
Absolutely.
All right. Well, George, thank you again for today. And could you please read us out?
Thank you, Louise. Always a great pleasure talking with you and speaking to interesting people like Amandeep together. Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek, Octopod Productions. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. And don't forget, you can visit pulseit.news to sign up for the e-newsletter and explore Pulse IT's massive digital archive. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind. Bye, everyone.